Alright, so good day everyone. Sitting here with us is the incredible Mr. Loo Guo Hou, an expert in the field of bariatrics and upper GI surgery. With a passion of transforming life through cutting-edge surgical care, Mr. Loo is not just a surgeon, he's a game changer in the world of metabolic health. His journey has been nothing short of inspiring, an MBBS from Jinmer in India, MRCS from the Royal College of Surgeons in the Islands, and a doctorate in general surgery from UKM. And today, he's a driving force at Upper GI and Metabolic Surgery Unit at Hospital Chancellor Tunku Muris and a clinical lecturer shaping the next generations of surgeons. From performing life-changing procedures like gastric bypass and complex hernia repair to advancing research on obesity and metabolic disorder, Mr. Loo is all about innovation, impact, and improving life. So let's dive right in and learn from this extraordinary mind. Welcome, Mr. Loo.
Thank you very much. So, and thank you for that very good introduction. But actually, I'm humble. I'm actually still learning. In our faculty, there's not one person. There's always a team. All right. It's even I think if you do studies, you always you have a group, and I think that's how we can go further and higher. And we are always thinking about patient. Our patient comes first, and whatever it is, patient outcome and safety is always our number one priority. Our unit, our Upper GI and Metabolic Surgery unit is headed by Prof. Dr. Nick, assisted by me. I'm the general and bariatric surgeon, and currently in pursuing of my Upper GI subspecialty training. Okay,
thank you, Mr. Loo. So without any further ado, I would like to begin with background as the first part of our interview. So alright, Mr. Loo, may I know what actually inspired you to pursue surgery as your career, and specifically, why did you choose Upper GI and Metabolic Surgery as your subspecialty?
Alright, that's a very interesting question actually. When I was in medical school, to be honest, what I was interested in actually obstetric and gynecology. Because when in India, our exposure to ONG was much more profound. We started conducting deliveries even when we were third-year medical students. So I think, and by the time I was an intern in India, we were managing postpartum hemorrhage. We were conducting, complex procedures. So it really inspired me to do something hands-on. So when I came back, I realized that perhaps ONG is not as better fit than surgery. So I did my housemanship in Selayang Hospital. So there, Dr. Fitzgerald, he's now Dr. Fitzgerald, our head of general surgical services. He actually inspired me to do general surgery. And general surgery, honestly, truth be told, it is a lot of hard work, right? Especially early in your career, and you have to come early. You have to put in the hours. On average, 10 to 12 hours every day. Monday to Sunday. As long as your patient needs you, you have to be there. And why Upper GI, why bariatrics? Because you have to understand, obesity is always regarded as something, a lot of people have different opinion about it. And if you ask everyone, a lot of times people always blame the patient, you're not disciplined enough, you're eating too much, you're not exercising enough. But ultimately, I think it's multifactorial. So, and it is a chronic disease as recognized by the World Health Organization. And what I'm part of is we are trying to do more of a preventive surgery and a preventive treatment to prevent and hopefully induce remission in a lot of chronic diseases such as diabetes, high blood pressure, cholesterol, heart disease, stroke, even cancers. So it is a step forward, and Malaysia, unfortunately, our obesity rates are very high, and yes, and it is going higher if I'm not mistaken. All right, so that's the truth, and we need to do something about it. That's why I pursue this subspecialty.
So do Mr. Loo actually find any much difference between ONG and also general surgery, other than a lot of hour in the
I think because my exposure for ONG is purely confined to when I was a medical student and housemanship. After when I became a medical officer, my ONG exposure was kind of only when they called me on table for some additional lysis, some removing of some additions, and if they have any struggling or any difficulty. So I would say that it is still a surgery, but perhaps ONG might be more taxing because you're dealing with two lives, the baby and the mother. Yeah, so to me, ultimately, it depends on what you choose to pursue. Yeah.
Right, thank you, Mr. Loo. Alright, so move on to the next question.
Sure.
Can Mr. Loo briefly elaborate on the educational pathway and the training experience that have led you to become a general surgeon, particularly in this specialty?
Alright, so for this training pathway, the one I pursue is basically the standard pathway to be a general surgeon in Malaysia. If you want to be a general surgeon in Malaysia, unfortunately, there's only one pathway. It is through the conjoined board of exams from all the universities. So you will need to go through becoming a medical officer in the surgical department for several years. After that, you can take up the Masters of Surgery or Doctor of General Surgery, in which are offered in various public hospitals such as University Malaya, National University of Malaysia, UKM, UPM, UITM, as well as USM. So this program is a 4-year program, and after that, when you finish your gazettement for 6 months or 1 year, then about 2 years into general surgery, you can consider to pursue subspecialty in various departments such as breast and endocrine, vascular surgery, colorectal, hepatobiliary, as well as vascular surgery. So, and upper GI. So this is the standard pathway, and I think most consultants do pursue this standardized pathway.
So this standardized pathway usually take out how many years?
You mean from after you finish your medical school? So after you finish your medical school, you have 2 years of housemanship and minimum of 2 years medical officer. So including 4 years of Masters of Surgery, it will be total of 8 years. After 8 years, usually about 2 years after you finish your specialty program, before you enter your subspecialty training, which is another 3 years. So I will say about 12 years.
12 years.
Yes, at least 12 years.
At least 12 years.
Yes.
It's interesting.
Yes.
Mr. Loo is alright with you, then we will now move on to the next section,
Sure.
okay, which is a professional insight sections.
Alright.
So here are some of the questions which I found I'm very interested on, and I believe that my peers and also the viewer will also find it interesting,
Yes.
right? Because it's actually both inspiring and also truth-provoking. Right, so on number one, question number one is, could doctor just walk us through a typical day in your life as a surgeon? I think it must be very eventful.
I would say so far in UKM, actually, it depends on what you want to do. So there's a saying, if you like your work every day, it doesn't matter, you just come and you don't feel like it's work because you're doing what you like. And that's why most important thing is you have to be passionate about what you do, regardless of whether it is something you pursue as a career or it's something you pursue as a hobby. As long as you're passionate about something, you will go far and you will never be too laborious. So a typical day would start off at about 6:15. Okay, 6:15, I will wake up, do some exercise. So usually I do about half an hour of exercise because as you advance in age, you need to keep up your stamina and you need to exercise. If not, you will not go far. We're not talking about long surgeries. We're just talking about the continuous work. So you need to keep your body fit. Normal day will start about 6:15 in the morning, where I will just go for about half an hour of treadmill exercise with a strength training. I'll typically reach the hospital about 7:30, 7:45, and then I'll start off my morning rounds to see review of my ward patients. That will usually take me about half an hour to an hour, depending on the amount of patients. I will then either go to clinic, to the endoscopic suite for upper and lower scopes, or to the OT. If there is some free time, I will try to chip in some education and teaching as well during the ward rounds, because usually I will have some year 3 and year 5 medical students tagging around the rounds, and it's actually a very good exposure for them, and we do it spontaneous, where we see the patient and then they can tell what they actually observe from then, and then you can see how the patient is being managed. So if, for example, if it's a Monday, it will be a clinic. So our clinic is almost a full day clinic where approximately 80 or 90 patients are being attended to. So after our clinics, we will do our pre-operative rounds for our patients who is scheduled for surgery, or elective surgery, and then sometimes our consultants also come and do rounds, and usually my day typically ends about 7 or 8 p.m. Okay, so in between I'll need to slot in some time for research work, student guidance. I have some master students under me as well, and of course the regular hourly teaching session, the formal teaching session for my year 3 and year 5 medical students as well. So I do work from Monday to Sunday unless I'm off elsewhere for some workshops or some training, and that so it is quite taxing, but again, if you love what you do, you don't feel it. Yeah.
Out of this routine,
Yes.
is there any special day?
Special day I would say would be my elective OT day, because that's on every Tuesday, because that is when I feel it is still why I'm doing surgery, to bring better patient outcomes. Most of our surgeries encompasses obesity surgeries, involving functional surgeries such as fundoplications, as well as upper GI oncological surgeries, which involve removing of the esophagus, reconstruction, as well as removing the stomach and reconstruction as well. So, of course, hernia as well. Hernia repairs, we do hernia repairs as well, and from inguinal hernias to incisional hernias, umbilical hernias, we do quite a few of them as well.
So out of so many surgery,
Yes.
which one is actually the most common one now?
I would say the most common now would be our metabolic surgeries. For example, procedures like sleeve gastrectomy, for example, one osteomosis gastric bypass, as well as Roux-en-Y gastric bypass. Yes, we do quite a few of those. And in fact, our center is the highest volume in the entire Malaysia, highest volume in terms of bariatric surgeries. Yes.
Yeah. So for the second question,
Yes.
I believe that every specialty actually has its unique challenges.
Yes.
So what do you think is the most demanding part of upper GI, so metabolic surgery? Is it the complexity of the case, the long hour, or perhaps something else?
I think it is more of various factors. It is never very complex cases or anything. More importantly, I think what is most challenging is getting the public perception to change that. And of course, with the change in public perception that obesity surgery is not cosmetic surgery, hopefully, the people higher up will realize that this is a systemic problem and it has to be tackled with adequate resources, with patient education and community outreach programs. And they do it eventually, even the insurance, those stakeholders, the insurance providers, that they realize that this is something that if we tackle early on, you can save a ton of money. We're talking about billions, because it prevents type 2 diabetes, it prevents heart problem, it prevents cancer, it prevents stroke. So if you can treat obesity, you're treating other things, it's always cost saving, so that is very, very important. I think the challenge is where trying to change that perception. There's something where me and my consultant has been working on for years, trying to change that perception. Because a lot of times, even if I talk to a doctor who is not in upper GI unit, they will ask me, why are you doing this surgery? Patient has been obese for years. They do not understand that, yes, patient has been obese for years, but what you're doing, it will change and have a profound effect on the patient's subsequent life, the quality of life and even the longevity. Studies have shown if you can treat obesity, you actually make their life, they live longer, in fact. Okay, yes.
So the most difficult part is actually to change the mindset.
Yes. That's the mindset of the patient and the people,
Okay, so this is actually personally for myself.
Sure.
So as a medical student, right, I often think about what can I do now to actually prepare for a potential career in surgery.
Yes.
So what kind of skill or experience would you advise to the student to actually focus during their undergraduate life?
I think when you start your medical clinical years from year 3 onwards, it's very important for you to be observant, observant and engage yourself as much as you can, because nowadays we are going towards self-directed learning. So when we talk about self-directed learning, a lot of your hours when you become a third year are actually dictated by how you want it to be, what time you want to wake up, how many hours you want to spend in the clinic, how many hours you want to spend in the ward or the OT or the endoscopic suite. So you have to understand, the more exposure you have to patients and how they are being managed, the better, more clinically oriented you will be, and in depth you will understand. In fact, I let my medical students from year 3 onwards to do simple procedures like bedside TNS, bedside cannula insertion, of course supervised, and things like even peritoneal tapping and all. Yes, you can learn from then on, and it always have to be supervised. So for example, if you go to a clinic, then you are browsing the files and then you just clock the patient. If there's no one guiding you, you are not sure which part are you. For example, a simple thing as history taking, you will not be accustomed to what we want and what we are looking out for. Things like the basic clinical signs and symptoms, and of course your clinical examination. So guidance is very important, and how much time you engage is very important. And of course there are courses like organized, for example, basic surgical skills course, and also the Academy of Silent Medical. They do have cadaveric workshops, and I think it's very, very helpful for medical students to get exposure in surgery. And that actually, when you can cut, you actually feel that yes, you want to do surgery. Because I was saying, the more exposure you have to your clinics, and if we keep seeing your faces, we feel that yes, you want to learn, because always learning is a two-way process. There has to be a willing teacher and there has to be a willing learner as well. So it goes hand in hand. There's no point if I'm a very dedicated teacher, but then when I come and see, and then you guys will be playing with your phone and they're not interested. Yeah, so it's very difficult. So it has to be willing teacher, willing learner. Both of us go hand in hand, and then yes, can go far. As teachers, we feel that yes, when we teach on a topic, we also gain different insights on how do we teach, and how do we actually how the approach is to make you better understand certain subjects. And surgery is all about anatomy. So when you learn, you have to be very, very observant how the patient looks, how the patient behaves. If a patient is really gasping in the ward or unresponsive, it doesn't take a medical student to recognize that this patient is ill. any lay person will recognize. But if you are observant enough, eventually you pick up subtle signs that will actually show you that yes, this patient is going to be unwell. So you tackle it then, so that the patient doesn't deteriorate further. So it's the same with surgery. We know not every patient is suitable for surgery, and not always the option or the solution is surgery. We have to cater our patients. Some patients just require some medications. Some patients require some simple counseling, and always empathy is key. Patients have to believe you are actually genuinely trying to help them, whether it's with surgery or non-surgical interventions. So I think that's key, and most importantly, to develop the surgical passion is to start once you are entering your clinical years. Sometimes when you see surgeries 3-4 hours long, and then you are standing there, you probably don't even know what the surgeon is doing. So you can always ask questions. Everyone is part of the team. It's not just the surgeon, the medical officers, the house officers, the nurses. The nurses are actually very, very experienced. You can even ask them. I'm sure they're more than happy to point you, this is what. Yeah. All right. So slowly start from there, and then once you get more accustomed to, you even can scrub in and be part of the team. In fact, just the previous batch, my third years, some of them actually came, scrub in and assisted, cut sutures and all. So I think early exposure, if I give them early exposure, they will be happy. They will be happy, and their passion will develop from there.
Right? Yeah, so it's basically you have to be observant,
yes.
You have to be enthusiasm,
yes.
And also you have to be really disciplined. Exposure also very important.
Yes.
I think apart from enthusiasm, self-confidence is also very important.
Of course.
To get self-confidence, you have to really practice a lot.
Confidence comes when you have adequate knowledge, adequate experience. Okay. But of course, when you start, you will not have confidence. It's a true practice. Okay. And as my consultant always say, do better or better don't do. I always believe that, because if you want to do something, you have to make sure that every single thing you do, you have to be perfect. You have to try to achieve perfection, and no one surgery is the same. Every surgery is different, and every surgery, even simple procedures, we learn from it. And at this point of time, I'm still inserting line, because I do not want to lose that skill. Like simple granulas. It's simple as that, but it's very rewarding if you get it, and I still feel that rewarding feeling if I'm able to insert the cannula. All right. Yes.
Alright, so thank you, Mr. Loo. Alright, so now we'll just proceed with the final section of the interview.
Sure.
So we'll be talking about the topic of challenges and also growth. So I've prepared one question here. Yes, Mr. Loo, I believe that every surgeon seems to have that one case that really stands out among the others. Okay, that moment that really tested their skill, resilience, or perhaps their perspective. Alright, so would you mind sharing the most challenging case that you have ever encountered?
I wouldn't say there's one particular case that stand out in the back of my mind, but I would believe every surgeon have what we call a graveyard, in our hearts, where we learn, unfortunately, from our mistakes, and patients suffer from it. It can be most of the time it is through our learning curve, where if we have a bit more years, a bit more experience, we can prevent such complications. Again, hindsight is always 20/20. So yes, you can say, I should have done this, I should have done that. But always remember to call for help and have the right guidance. If you have the right guidance, if you call for help at a timely manner, a lot of times mistakes can be avoided. Before this, I was serving in Sarawak for approximately 3 years and also as a medical officer, as well as a surgeon. Before I joined UKM. So sometimes where there are some centers where I'm alone, where I need to make decisions whether to go in for surgery for patient or not to go in. So I think the decision making part is very, very important. But that being said, I'm human as well, so I do have mistakes, and sometimes, for example, if for surgery I did a colectomy and then the patient leak. But yes, we learn from it. We have to go in, damage control, go in with a consultant, and then do what we can, and usually patient will be all right. So not really any challenging case that I can think of particularly.
So basically, you usually face a lot of challenges.
Yes.
Grow from
Correct. I think it's the same with life. Eventually, everyone has their own hurdles, and it's just that we are all in a different phase of time. I was once a medical student as well. I have my own challenges, and eventually, you will have your challenges as a house officer, as a medical officer, and we grow from there. Yes.
Thank you, Mr. Loo.
Well,
Alright, so before we end with our interview, is there any words that Mr. Loo would like to convey to our viewer or medical students, or maybe some of them might be pursuing this subspecialty? Any advice you want to give?
I think the most important thing is you have to have the right heart. When you come to work or when you come as a medical student to learn, you have to believe that you want to learn because you want for the betterment of the patient. It's always service above self. Nowadays, we always think there's this fad, or there's this trend where we talk about work-life balance. Even at my stage of my career, I'm still having a work-life imbalance. In fact, some people may view it as imbalance, where I work 10 to 12 hours a day, Monday to Sunday. But to me, no, because I'm doing what I love, and I know that I'm doing it for my patient. So I do it with passion. If, for example, today's case in point, it's a case where it's not even my elective day today, but initially she was actually slotted based on other available OTs. But because that OT somehow was occupied, I had to find ways to do that surgery regardless. So we discussed with our anesthetist colleague, and they have very helpful to give us an OT slot, and then we are managed to do that patient. So most importantly, when you want anything that you learn, you have to have a good heart, and you have to have the right intentions. If you abide by this, I'm sure you'll go far, regardless of whether you choose to pursue surgery, you choose to pursue ONG, orthopedic, or internal medicine. That's very important.
Right. Thank you so much, Mr. Loo, for sharing your incredible journeys and also insight with us today. Okay, so your passion just now is really inspiring me. I think really inspiring all of us here today. Right. So your passion of advancing bariatric and also metabolic surgery, as well as your commitment in education and collaboration, is a testament to the impact one individual can have on both patient and also the medical community. So we wish you the very best in your future endeavors, and also we hope to see even more groundbreaking achievement from you in the years to come.
Thank you very much.
Thank you, Dr. Loo. Thank you, Mr. Loo.
Thank you.